interdisciplinary approaches to survivorship. So I can't state how important survivorship is in the realm of cancer. The pediatric side has a very nice program to cancer survivorship, and the solid tumors and liquid malignancies in the adults do. But often our brain tumor patients get neglected in this group, especially our low-grade tumors and benign brain tumor populations, hence the focus of this talk. So in terms of cancer survivorship, physical symptoms and conditions precipitate the patterns and quality of care. There's a huge economic impact, and I can't tell you how profound that is. It depends on which state you're practicing in. And I can tell you from my point of view, having worked in Massachusetts, in Maryland, in Georgia, and now in Ohio, there's a huge discrepancy in the economic impact. And one of the things I'm doing is an MBA and looking at the sort of healthcare ramifications of the finances involved. There are special populations of patients. So in the brain tumor world, we think of the benign brain tumors. So often I get contacted by my colleagues in neurosurgery and they say, you know, we took this vestibular schwannoma out, or we took this meningioma out, but this person still has all these symptoms. Can you please help? So this clinic does plug those patients in and helps greatly with the patient's concerns and also helps my colleagues. There are research tools and platforms to think about. So for example, patients with the same diagnosis, both receiving radiation, both receiving chemotherapy, fare very differently, and why? So those are questions that there are people in my institute that are looking at those neurocognitive aspects of cancer outcomes. Disease progression, recurrence, and survival. So the better we monitor and the better we support this group of patients, they don't lose out in terms of their overall care. The health behaviors. So often our patient groups have mood issues, and as a result, their health behaviors might be far from beneficial. And so how do you improve those? And then the quality of life metrics and psychosocial issues. So teaming up with a good team of psychiatrists as well, rather than saying, I'm neurology, I can deal with all of the psychiatric issues. So this is a paper from Shapiro et al. From the New England Journal, and you can see cancer survivorship is increasing with time, and also as these metrics go up, so will the cost per capita. And we kind of need to look at this very closely. So in terms of the brain tumor survivorship care plan, which is a really nice algorithm set up by the Brain Trust in the United Kingdom. So you have the diagnosis, primary treatment, and after the primary treatment, there's the discussion of the survivorship care plan. So what we try to do at the University of Cincinnati is slightly change this. So at the time of diagnosis, we actually implement survivorship before treatment comes about. And why is that? Because we want to have the outcome metrics of the treatments that we give our patients. So for example, radiation. If you have very comprehensive neurocognitive testing, which we do at the University of Cincinnati for our patients pre-radiation, in collaboration with neurocognitive neurology, we have a baseline of what the patient is like before they even initiate the treatment processes. And we are able to fit our patients into these clinical settings within a few days. This clinic actually is becoming very successful. So we do the neurocognitive testing. We also set them up with services that we think would be very beneficial for them. For example, do they need rehab while they're undergoing treatment, or should they really have the rehab post-treatment? What is their age group? Do they need speech therapy? Do they need psychological counseling as they go through treatment, so that anxiety levels are better monitored? We've seen that in In terms of other cancers, outcomes are better if we invoke palliative care early. So do services like palliative care and integrative medicine help? So we're actually obtaining metrics from our clinic that we hope to publish in a year or so. So in addition, with the survivorship plan, we look at the sort of rates of remission, the rates of recurrence, and end-of-life care. And even though I've called it the low-grade glioma and the benign brain tumor population, we do have some of the IDH1 mutant GBMs and the high-functioning GBMs in our clinic as well, so that we can follow their progression with time. And we have KRAS sequencing on all of them as they come in. And so we look to monitor all the late effects, and if we have late effects, we offer them adjunctive treatment measures. And if they recur, we have treatment modalities in place with our colleagues in neurosurgery, radiation oncology, and of course ourselves. And we also, as I mentioned, discuss issues with palliative care. And so all our patients are aware that we can't keep them alive indefinitely. And this is particularly relevant to the discussion that Dr. Litvak had earlier regarding the high-grade tumor patients. So we help our patients recognize their journey early on, so it's not a sudden shock to their system. So in terms of the benign tumor types that we have in our clinic right now are meningiomas, low-grade gliomas, pituitary adenomas, craniopharyngiomas, and I don't have to go through all of the issues that these patients have with each of you. And in terms of brain tumor treatment-related effects that the NCCN survivorship has, so what we do is we have all these options available for our patients. So for example, patient comes in with anxiety or depression. We don't just put them on an SSRI. We start talking to integrative medicine, and we have a very good program here. Our program leader is from the Cleveland Clinic. And we do mindful meditation sessions virtually and in person, yoga. We provide social support through counseling, cognitive behavioral therapy. We have a really nice network within Cincinnati of free cancer counseling. It was a charity that was set up a long time ago. And so we have a partnership with them. And with that group, we also have brain tumor support groups that meet every month. And a provider in fact, we're having one next Tuesday. And in that one, they want to talk about cancer survivorship. The following month, they want to talk about clinical trials with me. So we have topics, and then we have breakout discussions for our patients. In addition, there's physical therapy. We're actively involved in these sort of rehab programs, and we can plug them in very rapidly. We have charitable institutions that pay for psychotherapy for our patients. We do offer medication adjunct, and we make sure that they're really tucked in. Fatigue issues, we do sort of fact questionnaires to do with fatigue and try to measure a metric. And then we look to see what the sleep disturbance patterns are. And we use the CBTI for that. And if they need a sleep study, we can plug them in within 2 weeks. We offer exercise programs and mindful-based stress reduction techniques, light therapy, and we have a cancer nutritionist that also works with our patients. And in terms of the cognitive side, Dr. Schatz, who's in neurocognitive neurology, helps quite a lot with sort of medication adjustments for our brain tumor patients. Balance-wise, we have Ravi Sami, who runs a neurootology clinic, and that's super helpful to have a skull-based surgeon with an interest in rehabilitation. In terms of the hearing issues, we are developing programs to help with depression that are non-medication based. Seizure issues, we have a fantastic epilepsy team that sees our brain tumor patients within a few days. So in terms of timing of survivorship and support services, this is how we've designed our program. We have a prehabilitation program that is before cancer rehab occurs. And the survivorship cognitive clinic basically spans the whole gamut of the prehab onwards. And we have a detailed plan of care for each of our patients. And we make sure that there's regular follow-up of our patients. You might be wondering how I do this and run a multi-D clinic and the adult NF clinic. Well, I've trained some very good mid-levels that run this clinic and report back to me. So in terms of summarizing the harmony needed for survivorship to operate, we need many services. So we can't say that we're neuro-onc on our own. So the cancer survivorship, neuropsych, integrative medicine and palliative care, rehabilitation medicine, we work as one unit to help our patients have the optimal quality of life, and hopefully this enhances their duration of life. There have been a number of patients that I've had in the GBM area when I arrived in Cincinnati that were unresectable. And I'm glad to say these patients are still with me because we've tweaked their metrics and they're on standard of care agents and they're doing pretty well. They won't be around for too long, but because of the extent of their disease, but at least if you optimize them at the beginning, they might have a better outcome. So this is something that I will be sort of writing about and publishing on in due course. So in terms of the clinic itself, we have a beautiful building and we run the clinic with 2 mid-levels. My neuro-oncology physician's assistant and the cancer survivorship NP. I have a CRA who's hoping to go to medical school and she's just fantastic. She's been trained to do all the neurocognitive testing tools. Rana Schatz, neurocognitive neurology, interprets all our detailed testing. And we've, as I mentioned, the channeling of the patients to the appropriate services. We also run clinical research projects in the survivorship space. So the 2 studies that, one that's just being approved by the IRB, it's called the ARMCAN study, and it's an expressive music study. So Claudia Rabola, who's a clinical research dean at the School of Design at the University of Cincinnati, also known as DAP, she and I designed a music app for expressive music therapy. And we're going to be piloting the study in the spring on breast cancer patients. And then we have the SITAR study, which is coming out, which is an art therapy platform study with pet robots. And we're doing that on vestibular schwannoma patients to see if we can improve their depression metrics by using interactive therapy rather than medication. So with that, I would like to say thank you to the team I work with. I couldn't do all of this without a fantastic team. My own team has my PA, Hudi Rothman, Abby Kohler, and Brandy Turner, who's a fantastic nurse. Survivorship is Melissa Erickson and Michelle Kirshner. Rana Schatz in neurology, and of course, Claudia Rabola at DAP. Thank you very much for your time.